All right, so with your trauma assessment, you're going to be getting a dispatch. So you're going to say, or the proctor is going to say, you have let's say a 20s male that was struck by a car, okay? Or it could have been ejected. It's going to be something really bad. So you're going to say, ambulance 1 respond here. Upon your arrival, you find your patient lying supine, flat, face up, in the middle of the intersection. Police department's there, and go. So the second you start, you have 10 minutes to complete the skill. Okay? So the second you start talking is when time starts. So first thing, standard precautions, make sure my scene is safe. I definitely have a mechanism of injury. The patient was struck by a vehicle, so a mechanism of injury versus the nature of illness. I have one patient right now. I definitely want to call additional resources. I want the police department here to control the traffic. I want fire department here for extra help, and consider ALS at this time. And I definitely want to have my partner hold the head in a neutral inline position. All right, so partner, number 1, your imaginary partner you can just point to. So partner, go ahead and hold the head in a neutral inline position and don't let go until I tell you to. Cool. So all that consists of is just for your partner just hold it. So now, my general impression. My general impression as I walk up, I have a 20s male who's lying supine in the middle of the intersection, and it appears to be he's unconscious, doesn't really look too well. Okay? Perfect. For airway, so as far as my general impression, my ALVA. So my patient is clearly with their eyes closed. So the first thing is my verbal, sir, open your eyes, open your eyes. No response to verbal stimuli. So now I'm going to go in for a trap pinch. I pinch their trap. Ugh. So he extends out and moans and groans. So thinking about my GCS, right now eyes were a 1 because they didn't open. Verbal was incomprehensible, garbled, so that's 2 points. And as far as motor, my patient extended out. So that's also 2 points. So right now my GCS is 1, 2, 2. Okay? Now as far as my chief complaint is going to be altered mental status. Because my patient's altered, they're not acting appropriately. And then you're going to ask, proctor, do I have or see any life threats at this time? Proctor will say yes or no. Most likely will say no, because they just want to keep you on track with everything. So proctor, do I have any life threats? Not at this time. Okay, now I want to move into my ABCs. So partner that's holding the head, can you open the airway using a jaw thrust maneuver? Okay? Proctor, I'm going to look in the airway. Do I see any type of vomit, any blood, any secretions from the airway? Let's say you see blood. Okay? So at this time, proctor, I want to go ahead and suction the airway. In this adult patient, I want to suction no more than 15 seconds in a spiral motion on the way out. I want to go no further past the base of the tongue. Okay, proctor, is the airway clear? Ask that. Okay, proctor says yes, airway is clear. Now I want to secure the airway. Based on the fact that my patient responded to painful stimuli, I want to go ahead and insert a nasopharyngeal airway, an NPA. Now, proctor, do I see any facial trauma to the face? That would be a contraindication. No, you don't see any facial trauma. Okay, so I want to measure from the tip of the nose to the earlobe. I want to insert the NPA using a water-based lubricant. I want to insert it. Proctor, does the patient accept the airway? Yes, patient accepts the airway. Okay, so now I want to move on. Now that airway's done, move on to breathing. At this time, I want to check rate, rhythm, and quality. So proctor, what's the rate, rhythm, and quality? I can check an O2 sat at this time as well. You get down low. The proctor tells you, okay, the rate is fast, the rhythm is irregular, and the quality is shallow. So in other words, all of it is ineffective. Okay, at this time, I want to ventilate the patient using a BVM. So other partner, go ahead and use a BVM. Let's ventilate the patient once every 5 to 6 seconds. Each ventilation's over a period of 1 second. I want to hook up that BVM to 15 liters per minute high flow oxygen. I want to make sure I get good chest rise and fall. Okay, so that's done. Now, I want to go ahead and start to cut clothes off. I want to expose my patient. I want to go ahead and look at the chest. Proctor, do I see any injuries associated with breathing, such as a sucking chest wound. Do I see paradoxal movement, or do I feel any type of flail chest segment? So I can go ahead and palpate. I can push down once, push in once, feeling for any crepitus, anything that could affect breathing. The proctor says, yes, you see a sucking chest wound, okay? Immediately, I'm gonna put my gloved hand over it. Other partner, go ahead and put a 3-sided occlusive dressing on exhalation. A 3-sided occlusive dressing on exhalation. Okay, so, patient exhalates or exhales, 3-sided occlusive dressing, done. Do I see any injuries that affect breathing? No. Okay, now I can move on to circulation. At this time, proctor, I want to grab a radial and a carotid on the side that I'm on. Proctor, what is rate, rhythm, quality? Remember, rate is just fast or slow. It's not a number, not a number. Okay? Let's say I have an absent radial and a weak, fast carotid. All right, that's a huge red flag. Partner, write that down. I have an absent radial because there's no pressure to create a radial, and a weak carotid, that's really bad, and it's fast. Okay, partner, write that down. At this time, I want to do a blood sweep. Now, a blood sweep is going to check for obvious profuse bleeding, tons of blood, life-threatening, bright red bleeding. What you're going to do is, it's a quick scan. You're going to take your hands starting at the head, always starting at the head. You're going to take your hands, you're going to scan. Proctor, do I see blood? No. You're going to tuck your hands behind the head, behind the neck. Do not lift. It's just tuck. Proctor, do I see blood? No. Proctor, do I see blood? No. You're going to tuck behind them a little bit. Do I see blood? Do I see blood? Do I see blood? Do I see blood? Now, starting away from me, blood, see blood, do I see blood? You're going to be exaggerating. You're going to put your hands basically not in your face, but you're just going to look at your hands. Do I see blood? Do I see blood? Do I see blood? Your proctor will say, maybe at some point, oh my gosh, there's a lot of bleeding to the leg. Direct pressure. Proctor, does that stop the bleeding? No. Okay. Other partner, put a tourniquet on the leg immediately and a pressure dressing. Proctor, does that stop the bleeding? Yes. Okay. I'm going to continue on. I don't care anything else about it as long as the bleeding's controlled. Away from me. I see blood, blood, blood. I see blood, blood, blood. Blood sweep is done. Now, proctor, I'm going to take my gloved hand, pull it down. Proctor, what's the color, temperature, and moisture of skins? Skins are pale, cool diaphoretic. Okay, that's another bad sign. Partner, write that down. I can check a capillary refill. Let's say it's delayed. Huge red flag. Okay. Now, based on my patient's ABCs, their chief complaint and their condition, as well as their GCS. GCS, we said, is going to be a 1 for eyes, 2 for verbal, and 2 for motor because they extended out. So GCS is 1, 2, 2. This is a bad GCS, bad overall impression. I definitely want to load and go immediately. Okay, so at this time, partner, go ahead and get the gurney, get the backboard ready. I'm going to do a rapid trauma assessment. Copy. Other partner, go ahead and attempt a sample history. Attempt a sample history. Okay, so now I'm going to do my rapid head-to-toe assessment. Starting at the head, I'm going to take my hands, I'm going to fan them through the scalp, the head. I'm checking for proctor, I'm checking for decap, BTLS, deformities, contusions, abrasions, punctures, penetrations, burns, tenderness, lacerations, and swelling. Okay, so all you have to do is say it once. Everything else, you can just say decap, BTLS, and that's okay. So now, I'm going to fan proctor. Do I feel any decap, BTLS to the head? Let's say he says, you have a bump on the head. Partner, write it down, the hematoma to the right head. Cool. I'm going to palpate, use my thumbs. Palpate the orbits around the eyes. Palpate the frontal bone, the forehead. Palpate the cheekbones. Okay. your zygomas, the nasal bones. Take a pen light. I'm going to check the pupils. Let's say pupils are bad. This one is fixed, this one is sluggish. Okay, it's not good. I want to check the ears. It's okay to lean over. It's okay to lean. Do not turn the head sideways. Defeats the whole purpose. So it's okay to lean. Proctor, do I see any fluid or blood in the ears? Or do I see any bruising, battle signs behind the ears? I'm going to check on this side. Do I see fluid or blood from the ears? Do I see anything behind the ears? Battle signs? No. Okay, moving on. This shirt was already cut off, like we said. Now I want to check the anterior, the front of the neck. Okay? Proctor, do I see any subcutaneous emphysema? Do I feel any subcutaneous emphysema? Which just looks like a bullfrog. Do I feel tracheal deviation? Talk about you're going to feel your trachea. It's going to start to push over. No. Okay. Do I see jugular vein distension? Neck veins in a supine patient is a good thing. Okay. The neck vein should pop out. Well, let's say the proctor says no. The neck veins, jugular veins are flat. In other words, you can't see them. Okay, that's bad. There's no pressure to make it pop out. Partner, write that down. There's no jugular vein distension. Got it. Now I want to check the back of the neck. I'm going to take my hand, I'm going to tuck them behind the neck, and I'm going to walk them, okay, like the keys to a piano, walk them, interlace my fingers like that, and just basically feel each part of the neck. Do not lift the head, okay? So tuck behind, walk down. Let's say my proctor tells me, okay, your patient, okay, so immediately I'm going to stop. Partner, they have pain to the back of their neck. Write that down. Copy. Now that I've looked at the front and the back of the neck, I'm going to size and apply my C-collar. So the C-collar goes on now. Okay? The chest, I'm going to start at the jugular notch. You have this notch right here. You're going to start right here and you're going to walk out. You're going to walk out. I'm going to feel the clavicle. As I walk out. Proctor, how's the clavicle? Good? Okay. Now, start up at that same jugular notch, as high up, like a karate chop. I'm going to push down once. Any area I did not touch, I'm going to move down. Push down once on the sternum. I'm checking the sternum. The sternum's connected to the rib cage via cartilage. So, push down once, that's it. Now, I'm going to check the rest of the rib cage. I'm going to take my fingers, make like a W, okay? I'm going to put it on the xiphoid. The xiphoid process is a little piece of sternum, right? So I'll put the thumbs on the xiphoid, and I'm going to fan out on top. I'm going to fan out as much as I can because I want to feel as much of the rib cage as possible. Okay? I'm going to push down once, and then push in once. Notice my hands are fanned out, so I can feel as much of the rib cage as possible. So once again, down once, in once, and that's it. Okay? Now, proctor, do I feel any flail chest segment? Do I feel paradoxical movement? Do I see any decap VTLS? No, not at this time. Okay, I want to auscultate lung sound. Proctor, I want to auscultate second or third intercostal space, mid-clavicular, bilaterally. Partner, ventilate, ventilate. Fourth or fifth intercostal space, mid-axillary, bilaterally, ventilate, ventilate. Okay? So we got lung sound. Now I want to check the stomach. You have 4 quadrants. The belly button, there's a line that comes down. The belly button, line that goes across. 4 quadrants. I'm going to take my hands, like hula hands. Okay? So just like hula, I'm going to take the heel of my hand, starting away from me. Okay? I'm going to palpate down so I can feel the whole entire quadrant in one motion. 1, 2, 3, 4. Okay? So proctor, I'm checking for distension, where it looks big. Is it rigid? Do I feel a pulsating mass? Do I see any discoloration, any bruising around the stomach? And do I feel or see any decap VTLS? Okay? Let's say the proctor says, when you palpate this upper left quadrant, ugh. Okay, so stop. Partner, write that down, upper left quadrant. Now, I want to go ahead and check the pelvis. You're going to take the heel of your hand. You're going to find the pelvis. You're going to push down once, in once. Okay? Don't do the down and in and out, and people do all kinds of weird stuff. Okay. Don't do that. If the pelvis is broken, you'll know it. You'll know it. Push down once, in once, done. Okay? So Proctor, how's the pelvis? Stable. Cool. I want to check genitalia. For males or females, I want to check for any urination, any defecation. Do I see any bleeding going on? So remember, if there's blood, it could be that the bladder has been ruptured, especially if there's blood coming from a male. Now, if there's bleeding coming from a female, they could be on their menstrual cycle, or they could have a ruptured bladder. We don't know. We're going to document it. Partner, write it down. We have bleeding. Let the physicians figure it out. Okay? At the same time, with urination and defecation, can someone be hit hard enough where they poop or pee themselves? Yes. But could they also have a spinal injury where they relax and they lose that control? Yes. So either way, it's possible. Partner, write it down. That's all we're really doing. Or else in males, do I see a priapism, which is an erection, which could be caused by a spinal cord injury. Okay? Either way, we're going to write it down, let the doctors figure it out. I'm going to continue my assessment. Starting away from me, as high up as I can go. I'm going to move the legs in a direction they're not made to move. So as high up, okay. Proctor, do I feel any decap BTLS? I'm going to grab the knee. Okay. Do I go up as high up as I can go? Now on the side that I'm on, push. Okay. Proctor says at this time, I feel a deformity to the upper leg, the femur. Okay. Does it appear to be closed? Yes. Closed meaning the skin is intact. It's okay. So in other words, it's inside. It's closed. So at this time, that's a secondary injury. Partner, write that down. We have a deformed femur. I'm going to put a traction splint in the back of the ambulance driving to the hospital. In the moving ambulance, I will put this on. Move down. Grab the kneecap. Move in the direction it's not made to move. Do I feel any decap BTLS? No, we're good. Now I need to check PMS in the feet. Pulses. I'm going to feel pulses. Let's say they're weak. Okay, they're absent on this side because I put a tourniquet on earlier. So absent but weak on this side, okay. I'm going to go ahead, since my patient is altered, I can't get him to move, so I'm going to pinch, pinch, so they responded, okay. So now I'm going to come back up. I'm going to check the arms, starting away from me. I'm going to feel up as high up as I can go, in direction they're not made to move. Grab the elbow, push in. Proctor, do I feel any decap BTLS? No. Come on this side. Direction they're not made to move. Grab the elbow, push in. Now I'm going to check PMS. Pulses. Pulses are, well, we're absent because we got absent earlier. Okay. So let's say I'm going to check motor and sensory. I'm going to pinch and I'm going to pinch. Do I get that response? Yes. Okay, at this time, I'm going to log roll the patient. Partner holding the head. Your 3 count, we're going to log roll the patient to the patient's left. In other words, towards me. I'm going to log roll the patient towards me. Okay? Hand on hip, hand on shoulder. Heads count, imaginary head, right? So 1, 2, 3. Log roll. This hand is glued. This hand is glued to the shoulder. It does not let go. This hand on the hip, yes, you will let go, okay? This should already be exposed. Okay, Proctor, I'm checking for decap BTLS. Do I see any decap BTLS? No. Okay, I want to inspect, palpate, auscultate. So I inspected for decap BTLS. I want to palpate. Now, you're going to feel the vertebrae. As high up as you can go, like the keys to a piano, you're going to walk your fingers down. Proctor, do I feel any step-offs? Do I feel any tinting? Skin tinting is where the bone pushes out through the skin, kind of like this, but doesn't break the skin. So like a camping tent, right? So do I feel, so let's say I push right here. The proctor says, the patient goes, ugh, okay, stop. Partner, write that down. Lower back, midline, pain. Cool. Check the rest of the back. Check the rest of the butt. Okay, check for defecation, urination, anything else. Back of the legs. Okay, we're good. Now I want to auscultate, or excuse me, I want to palpate the scapula behind here. So palpate, palpate, we're good. Now auscultate, subscapulary. Or ventilate, ventilate. Okay, we're good. Now I want to log roll onto a backboard. Onto a backboard. Heads count. 1, 2, 3. Log roll onto a backboard. Okay? So now I want to strap the patient down. After I strap them down, I want to recheck PMS in the hands and in the feet. Now I want to leave. In the back of a moving ambulance, I want to check vital signs first. I want to manage secondary injuries. And I want to reassess my patient every 5 minutes. Okay? Done.
Thank you.